This is Lori Manella. I'm here with the lecture on care of patients with renal disorders. These lectures on kidney, if you haven't determined it yet, and I've probably already said it a couple times, the first two lectures that you've been through, the first lecture was more assessment and anatomy of the GU system. The second one was disorders involved in below the renal system, outside of the renal system, or the lower GU system. Now I'm going to discuss with you some care patients with renal disorders, and these are disorders within the kidney themselves. Your book is kind of, it doesn't make as much sense unless you divide some of these up in this one manner. So within, as far as the GU system, utilize your text. Like most times, the MedSurg text is very large as a resource in looking up some of these disorders and reading them. There will be some stats and such that are different. I tend to utilize the Cancer Society, for instance, for cancer statistical values. Most times, values or stats will not be included in testing purposes, and as well as with NCLEX, because stats do vary depending on who who is speaking about them and what societies and such. So, care of patients with renal disorders. These are how we're going to discuss them. We're going to talk about congenital disorder, polycystic kidney disease, and within those we'll talk about the adult manifestation and the childhood recessive manifestation. As in the obstructive disorders, you will see hydronephrosis, and anything that obstructs the GU system can, cause damage to the kidneys. We know dilation. We know the kidney itself only holds a few cc's of urine. It's the bladder that is able to hold and be a storage bin for the urine. Infectious diseases. Now, I've talked in lecture 2 related to UTI and division of it, how you can look at it as complicated, uncomplicated. Now, in comes polynephritis again, or this is upper kidney infection, because this is the UTI within the kidney, which of course patients are at greater risk because now we're talking about direct involvement within the kidney, not per se in the lower GU system, that would be more the urethra, the bladder, and so on. The immunologic renal diseases, 3 that we're going to talk about, are glomerular nephritis, nephrotic syndrome, Goodpasture's. So you're seeing things that affect the kidneys, generally at the glomerular level, and we know the glomerular helps to remove, infiltrate our urine. So we'll talk about these 3 together. Degenerative disorders, nephrosclerosis, in the word of it, you realize the sclerotic areas are things that are narrowed by scarring and such. And we'll talk a little bit about that. Diabetic nephropathy, you've discussed in MedSurg 1, but it is important to discuss as well. Renal cancer, we'll mention. I do use some stats from the Cancer Society, and renal trauma. So starting out and talking about congenital or a congenital disorder of the kidneys, this is polycystic kidney disease, or PKD. In some of these slides, I'm not going to read exactly what's on the slides. These are my notes, and others I will focus more on the slide itself. This is the most common life-threatening genetic disease in the world. It affects approximately 600,000 people in the United States, and it also accounts for the etiology of about 10 to 15% of those persons that are are in the chronic kidney state of disease. There are two types, and in the next slide we're going to kind of break those down a little bit more. There's an autosomal dominant, which is an adult form, and the childhood form, which is more rare, and it is autosomal recessive. The adult form can lay latent for many years, and then generally it starts showing or manifesting, the person manifests signs and symptoms about the ages of 30 to 40 years of age. So on this slide you see some of the clinical manifestations of polykidney disease. Nocturina could be one of the first signs and symptoms, and we know kidney overall, or if you're not aware, one of the first symptoms of kidney disease is usually fatigue. But nocturia is mentioned here on the slide. Pain in the kidneys or in abdominal or flank area. When you can palpate kidneys, they are difficult to palpate unless someone is emaciated, very thin, or they have a tumor or a swelling of the kidneys. So in polycystic, you see it's identified here that the kidneys are palpable, can be. Hematuria, and we know some of these signs and symptoms, and I want you to look at what's different in some of these kidney disorders. And hematuria is not one of those differences, but it surely is one of the manifestations. UTI. We know these cystic tissue is not functional tissue. It causes retention of urine in the kidney, hypertension, and with the hypertension, headaches. So, as I mentioned, polycystic kidney disease, predominantly there are two types. The more dominant form is seen in adults, and I discussed in that PowerPoint before this one, in the slide right before this in 4, that usually adults 30 to 50 years of age. And in this dominant form, the adult form, it is about 50% of those with the adult form of polycystic will develop kidney failure by 50 to 60 years of age. That's why it is so important to identify it and manage it with medications and treatment. In the dominant form, only a few cysts until the 30s, and this is the most common form. Dominant form itself, when we talk about this, 50% of children will develop this disease, this dominant form of the disease, if one parent has PKD. So it's only one parent need have it, and 50% of the children that they bring into the world will have this disease process. 100% who inherit the gene will develop cysts by 30 years. So all the folks who have the gene for polycystic kidney disease do develop this disease process. Now, in the recessive form, and I like to compare and contrast, it's a higher form of learning, and it really helps you to see clearly and differentiate. So you will see that I like to do this too, and I like to also utilize any charts that do this within your book. But the recessive form is rare, and most of the children diagnosed with this will die in early childhood. In fact, if they're diagnosed at birth, many children die very quickly after birth. Nearly 100% of nephrons have cysts with the recessive form. To inherit this disease, both parents must carry it or carry the gene. And when their parents both have it, there's 25% chance of a child inheriting the recessive polycystic disease. So it's more fatal. There is, both parents have to carry in order for the child to come up with the disease, and then 25% of the children with two parents with the disease will inherit this recessive polycystic disease. As far as PKD and other risk, cysts occur in other tissues or can occur in other tissues such as the liver and blood vessels, and the incidence of cerebral aneurysms are common. Some of the other risk from polycystic kidney disease, as I was saying, these cysts can occur in other organs, and also these folks have more aneurysms. In these patients, because of static urine staying in those kidneys due to the cyst obstructing the flow and such, many of these folks do have kidney disease, as you see. Also included on this PowerPoint slide, you do see the mention of heart valve problems. Diagnostic criteria. Their UA generally shows proteinuria, hematuria, rise in creatinine and BUN. The creatinine clearance decreases. It was mentioned earlier by a student or two, the most effective test I have mentioned either in one or two of this video series is creatinine, but the most correct thought process related to what is the best test for kidney functioning is creatinine clearance. But the thing about creatinine clearance is a blood test has to be done and a 24-hour urine gathering. And then they look at the two of them. If you're asked a question like that on the boards, creatinine clearance versus creatinine, would be creatinine clearance. What you will find in reality today, creatinine clearance takes some time to do. I said you have to do the 24-hour urine along with the blood test. And it is being shown, and I just read a paper or an article by Harvard, written by Harvard, or a professor at Harvard. There is nothing, the effectiveness of both of those testing, they don't show the need to do the creatinine clearance. The cost effectiveness is not there. And also, they also mention, and I guess this is further going to be drawn out, we might see more articles related to that or to this. There has not been shown, it's not cost effective, and there's also some false positive problems. So keep an eye out there. If you're asked again, creatinine itself can be done very quickly in a blood test. Creatinine clearance takes the 24-hour urine and a blood test. The creatinine clearance is supposed to be a more sophisticated and more specific test, but it is, in most times, they will just do a creatinine and they will do a GFR calculation from the creatinine. As we're talking about these folks and care, we're also going to look at sodium management, and that can be changing, of course, as their conditions worsen. Some diagnostic test, CAT scan, MRI. It is said, and your book mentions it as well, that ultrasound is the best screening method. Nursing management, collaborative care, prevention and treatment of infection. Remember, those cysts are kind of blocking and obstructing, and cystic tissue is not functioning tissue. So if they're experiencing an infection, they need to have antibiotics. Nephrectomy, if one kidney continues to get, for instance, an example, infected with UTIs and such, they may remove it. But we know over time these folks generally will go into an end stage. We know this is a genetic problem, that it's going to continue to happen. These folks aren't folks that are going to have a transplant, because this would continue happening. There's not a lot of information about that. Management of progressive renal failure, and we would do this for any of the causes of renal failure. Diet modification, you watch protein, you watch sodium. Of course, other labs are going to watch the potassium very carefully. Fluid restrictions, watching edema, watching skin and tissue. It's very fragile. Medications are generally ACE inhibitors and blood pressure meds, diuretics, and so on. And these folks need a lot of psychosocial support because this is a chronic condition. As far as genetic management, and your book went into this a bit, and I found it very interesting. They have developed more precise testing for the genetics related to the polycystic kidney disease. So we do in families, this is an encouragement for them to look at and make educated decisions related to having children with the knowledge that you have this gene. So kind of check that out in your book. Let's see. In your book, it does go through that, like I said, a bit of that DNA testing that's available. Up to 30 to 50%. I think I mentioned this just a little bit. Of affected newborns die shortly after birth. If they survive the newborn period, the chances of survival are good, but about 1/3 need dialysis or a transplant by the age of 10. So this is very interesting. Also in your book, a little footnote was that the genetic testing is also available to do on fertilized embryos before implantation, and this allows the embryos to be free of the disorder to be placed into the uterus. So that's another chance for these folks. If they're aware that they have these genes present, then perhaps in vitro, that could be one of their choices, and looking at the embryos, transplanting the ones that do not have this disease process. And we all know there's a lot of personal beliefs we have to decisions like this, but it is a choice that must be discussed with families. Obstructive disorders in the kidneys, the ones we mentioned here are hydronephrosis, hydroureter, and urethral strictures. And with these, there are problems with urine outflow, and the causes can be tumors, stones, trauma, structural defects, and fibrosis. When urine backs up into the kidneys, this exerts pressure on the kidney tissue, and this can begin as low as a few hours. The renal bladder, the renal itself, when we say renal bladder, we're talking about the kidney. The capacity is only, now you will see differences, but I have seen to the most 5 to 8 milliliters. I believe your book, especially edition 10, it might be 9 as well, it says 5, but it is small amount. So once in a while, when people are having these problems, we might see a temporary tube like a nephrostomy put in. This could be helping to save the kidney tissue at this point before it can be corrected. And nephrostomy tubes divert urine externally and prevent further damage. The nephrostomy is done in a surgical procedure, and they use a tube, a stent, or a catheter, and they insert it through the skin into the kidney. The purpose is to carry urine from the kidney to the bladder. When this tube is blocked, urine backs up into the kidney and irreversible kidney damage can occur. So usually with a nephrostomy tube, what we will see, and I have some pictures coming up, is we'll see the urine diverted into a small bag that comes posteriorly, out and back. It's on the patient's back, the lower back. This is a sterile procedure, and we have a couple more slides related to this, so we'll talk about it. It is generally done temporary. I have had a few patients where it was in for an extended amount of time. Okay, and I also do surmise that on here it can be permanent. It is inserted directly into the pelvis of the kidney. It is closed drainage. This is a sterile dressing when we do one of these over here. This is a picture of the little nephrostomy tube. It is very tiny and flexible. Risk, if they're having this put on, it is generally safe, but some major complications, injuries to the surrounding organs, infection, loss of tissue or trauma to the kidneys, delayed bleeding or hemorrhage, and blocking of a kidney artery. Catheters should never be kinked or clamped. Remember, the kidney itself, it's going directly into the kidney, only holds about 5 cc's of urine in there. So if the patient starts to complain of pain, we check the catheter for patency. They kink very easily. I told you that the dressing is, sterile, and also if an irrigation is ordered, and frequently it is if they have a nephrostomy tube. This is strict aseptic technique, and no more than 5 milliliters of sterile saline. Now, on the older slide on the PowerPoint that is online, you are going to see some subtle changes I make now and then, and one of these are, or have made before I recorded this, it on your PowerPoint slides that are online, it says 528. Your book says 5 mils. So just cross off that 8, but you're going to see that bit of range if you read in other materials. So it's gently instilled when we watch over distension of the kidney. Before changing a dressing on here, wash hands, remove the soil dressing. You will clean the skin around the tube. Now, when I mention a cleaning substance like chlorhexidine, know that wherever you're working in cleansing some of these areas, not only with a nephrostomy, but I will mention in dialysis, when a patient's taking peritoneal dialysis, for instance, another example, they will use a cleaning substance around that. But remember that something has to be that cleaning substance, okay? Don't get stuck on the chlorhexidine. It has to be a cleaning substance that's appropriate. And in your hospital facility where you work, you're going to make sure you realize the policy there. So you're going to use a back and forth scrubbing motion for 30 seconds, allow to dry, and place a 2x2, a sterile 2x2 around the tube. And Tegaderm goes over the site. Normal results of using this tube, the urine will drain into the small bag. And it depends on how long they're going to keep it in. They might have it in because there's a tumor or a stricture. They're waiting to see what surgical treatment they're going to do. Okay. One example of a more permanent nephrostomy tube, you can see it on the slide, is somebody that has end-stage cancer, and it's going to stay in place. Okay, this is performed by a radiologist or a urologist. Can be done inpatient or outpatient. And specially trained nurses, and we know these nurses, they're called wound ostomy nurses, usually help to consult for any of these ostomies, and that includes ostomy nurses will take care of and help talk with the nurse, talk with the doctor and the patient beforehand on a patient having a colostomy, any ostomy, trach, so on, at sometimes helping the healthcare provider decide where the best place for instance, the ileostomy or ostomy, because they can have a little bit of a variation with that. Well, this patient wears a belt, the safety belt's going to get in the way if we do it here. This patient likes to wear a big belt. Where can we put this? And so on. But these nurses also help with treatment, help patient care for themselves, teach them, look at different appliances, and they also, that you can put on colostomies and so on. And they also help with incontinence care with those who are plagued with incontinence, and maybe talking to them about different products they could use. Reasons for nephrostomy, which we talked about earlier, could be blocked by a tumor or a stone, or maybe there's a hole in the bladder, and ureters can be damaged so easily. It could be damaged from a patient having any abdominal surgery, and one of the things we watch out for post-abdominal surgery is any sign and symptom of bleeding or problems with urination where something could have gotten nicked and so on. They can also be done for diagnostic procedure to assess the kidney. Okay. Emptying the bag of a nephrostomy, it's got to be emptied when half full. Remember, the kidney, we mentioned, only holds about 5 cc's of urine. We don't touch the spout. It is a sterile area, considered to be sterile, so we want to be very careful. Tips: keep the drainage system below the level of the bladder, and this is to be done too with Foley catheters so that we don't have or encourage hydronephrosis from the urine backing up. Many times they wear a leg bag because the bag that is coming directly or that the nephrostomy tube is hooked into is very small. So sometimes that bag will be attached then to a larger bag that they can wear around the leg. And this will need to be emptied more frequently than like a Foley bag. You want to be careful that this tubing doesn't have any kinks or bends. Teach them these things we've been talking about. They will need help because the catheter is located on the client's back, so the dressing needs to go back there. We want to keep areas clean and dry. Don't drag it on the floor, some of the basic things. And if that bag should leak, it's got to be changed immediately. If the urine becomes, has a foul smell to it or bloody or any change, they are to report it. If pain increases, if they have a temperature, if the drainage stops for 2 hours. And 2 hours seems like a long time to me. Also, if the skin is breaking down around the tube, this is important. We know these patients are at increased risk for infection anyway, so we want to watch this very carefully. Now we're going to go into some other problems within the kidney. Here's acute pyelonephritis, and this is an upper UTI. We discussed UTI upper and lower within the last presentation, last Camtasia, but now it is being discussed again because we are within the kidney itself. We know that UTIs can be in the lower urinary tract infection, in the urinary tract, or the upper, excuse me. So the acute is when it is affecting the kidney itself, okay? The acute pyelonephritis is very common. It's one of the most common bacterial infection. It does begin in the lower urinary tract infection, and then this can travel into the kidney. That is why it's very important that, if possible, to take care of the urinary tract infection when it's lower, because it does become more serious. We know there's a greater chance of the kidney being damaged itself. And acute pyelonephritis, like any UTIs, but kidneys can be damaged more. This happens sometimes from when maybe the patient's having a diagnostic test, a scope of the GU system, or has had a catheter in or something like this. Some of the symptoms, all the lower urinary tract symptoms, plus fatigue, chills, fever, vomiting. Patient may also have tenderness on the CVA on the affected side. Diagnostic studies, UA, looking for polyuria, bacteriuria, varying degrees of hematuria, and WBC cast. And some of these normal and abnormal signs and symptoms were discussed in the last video. CBC, looking for an increase in WBCs, urine culture sensitivity, blood culture sensitivity, renal ultrasound, and renal imaging studies. Patients who have a urinary tract infection within the kidney itself, your book pretty much goes through it and it names some drugs. There is a little chart I see in the 10th edition I saw Patients out, they can have outpatient management, or if it's more severe, going to the hospital. They might give them some high potency IV antibiotics to get a nice level, and then put them on PO and antibiotics and DC them to home. A lot of good fluid intake. They may be put on Motrin. And remember, with Motrin, we want to be very careful with Motrin. It is a nephrotoxic drug. But if patient is not having signs and symptoms of, a chronic urinary breakdown or acute, then, Motrin is a very good anti-inflammatory drug for them. Urinary analgesics, they might be giving something like pyridium for the signs and symptoms, and follow up. Now, in urinary tract infection, I may have mentioned it in the last session, the last video. If it is a non-complicated, it is a first UTI, it is in the lower urinary tract infection per the signs and symptoms, patients can be treated empirically, which means the urine doesn't have to be tested. They will be given a PO, and it's only for 3 to 5 days. It's a short period of time. In fact, sometimes closer to 3 days. If they find they still have signs and symptoms, then the healthcare provider will do a culture and sensitivity to find out what the specific bacteria is. It must be a more unusual one. Some other reading that I did in the Harvard newsletter, and it was, I believe, in June of this year, it mentioned acute pyelonephritis, and it mentioned that healthcare providers treat, of course, pyelonephritis with antibiotics when they're more in the most, when they're uncomplicated cases, as I mentioned to you. Generally, in the acute pyelonephritis, now this has to, in an uncomplicated case of acute pyelonephritis, because of the severity now, it's within the kidney, we're not talking about the lower urinary tract infection, the antibiotic will be given for 10 to 14 days. Some common drugs that are used are trimethylprim, sulfonamethoxyl. This is Bactrim. They may use Cipro or levofloxacin, so these are quinoludes. Your book kind of goes against using that at the beginning, but this is, we know many of our books are several years behind when they come out, even the newest edition. So for realism, I think in your book it mentions amoxicillin. I'm used to more augmentin, which augmentin is a penicillin. It is amoxicillin, but with the addition of potassium gluconate. Okay, so in reality, a lot of Bactrim, Cipro, Levaquin are given in these acute pyelonephritis incidents. And once they finish it, they'll get another urine sample. If patient is still with a UTI, further testing will be done and stronger medications. Chronic pyelonephritis, and this is one of the risks of when you have a urinary tract infection within the kidneys. We want to watch out for a chronic pyelonephritis. The kidneys will become very small and shrunken, and they lose function. And this is usually due to recurring UTIs involving the upper urinary tract, the kidneys themselves. And the chronic pyelonephritis can often progress to an end-stage kidney disease. That's why we want to hit those UTIs, hopefully catch it lower before it gets up into the kidney. It becomes a pyelonephritis. If it's acute pyelonephritis, we want to hit it with that 10 to 14 days of antibiotics, follow up, because we want to decrease the risk of it becoming a chronic UTI. So polynephritis, here's one of our compare and contrast. The acute is going to have the active bacteria and usually follows a lower UTI. When we're talking about the polynephritis, so the UTI within the kidneys, we're seeing some of the systemic signs and symptoms as well as the lower UTI signs and symptoms. But the systemic are more the fever, the chills, can have tachycardia, pain, nausea, vomiting, malaise, and so on. Burning is one of the lower UTIs, and I've said with the UTI in the kidney, they generally have the lower UTI signs and symptoms as well as these more systemic ones. In the chronic UTIs, this is usually, or the chronic polynephritis, which is an upper UTI, repeated or continued infection usually cause them. And it often sometimes occurs with a defect in the kidney itself or an obstruction. Folks might have also signs and symptoms of hypertension because you're talking about kidney damage after having this for a while and ongoing, and how the kidneys do decrease in size and lose function, decrease urine concentrating, and high potassium. Now we're going to go into some immunologic renal disorders, pardon me. And three other ones we're going to talk about are glomerulonephritis, Goodpasture syndrome, and nephrotic syndrome. And these are each discussed in your text as well. Glomerulonephritis, this is an immunologic process. It involves the urinary tract, but predominantly affects the renal glomerulus. This disease does affect both kidneys equally. It is the third leading cause of end-stage renal disease. So if we look at the first three, number 1 is diabetes, number 2 is hypertension, and number 3 is considered to be glomerulonephritis, okay? And causing, these three are the leading causes of end-stage renal disease. This is in the U.S. Glomerulonephritis can be acute, or it can become long-term and chronic. So what's going on in the glomerulonephritis? Antibodies within the glomerular basement membrane. This is, remember, the glomerulus is used to help filter waste and extra fluid from the blood, a rather important part of the kidneys. In this disease, what we find is that the glomerulus produces antibodies against its own GBM. These antibodies react with the circulating non-glomerular antigens, and it's the perfect setup for disaster. Causes of infectious acute glomerulonephritis. The number 1 is a group A beta hemolytic streptococcus. So I'll say this over to you and I'll say it again, that it is important to prevent this, to prevent it the first time, an acute process or chronic. It is important to be tested and treated if we have a sore throat or upper respiratory infection. Make sure we go to our healthcare provider and are treated, so we don't perhaps down the road have a problem in the kidneys such as this. Other things that can cause it: staphylococcal or gram-negative bacteremia, syphilis, hepatitis B, mononucleosis, measles, any really bacteria, parasitic, fungal, or viral infection can lodge in that GBM. Secondary glomerular diseases: lupus, Schwann-Hanach, purpura, Goodpasture syndrome, which we're going to talk about that in a little bit, cirrhosis, sickle cell anemia, and there are many more. Glomerulonephritis, the clinical manifestations: blood in the urine, excretion of RBCs, WBCs, protein, increased BUN, increased serum creatinine. In the number 1 cause of glomerulonephritis, this is the acute post-streptococcal glomerulonephritis, or ABSGN. We have the clinical manifestations. We have hypertension, oliguria or decreased urination, hematuria, and this hematuria can be smoky or rusty appearance. The smoky indicates bleeding from the upper urinary tract. proteinuria, and this proteinuria varies with the degree of severity of this disease process. Fluid retention, which usually begins in periorbital edema or low pressure areas. It moves into ascites or peripheral edema, and then a more generalized edema. And also sign and symptom abdominal or flank pain. What are some of our treatments? You can see these in front of you: rest, sodium and fluid restrictions, diuretics, antihypertensive therapy, adjustment of dietary protein to the level of proteinuria and uremia, antibiotics if the streptococcal infection is still present. 95% of folks with glomerulonephritis and APSGN have a 95% or greater recovery and of complete recovery. Treatment is symptom relief and protection of the kidneys, lowered protein, and as I said, this is dependent on the amount of protein in the urine, low sodium and fluid restriction. We want, and I'm saying this for the second or third time now, encourage early treatment of upper respiratory infections. An antibiotic will be given if infection, that strep, is still present. If it's strep, generally penicillin will be given unless they are allergic. Okay, the second of the three genetic problems in the kidney that we're discussing on this lecture: Goodpasture syndrome. Goodpasture syndrome is rare, and whenever you have syndrome here, you know it's going to be one or more, it's going to be greater than one systems in the body that are affected. Okay, it's bigger than one system. It is rare. The direct cause is unknown, but there's a formation of antibodies in the GBM. It can also bind to the alveolar membrane, causing pulmonary hemorrhage. It usually affects younger folks, predominantly young male smokers. It can occur at any age, but this is the predominant age group and gender. Extensive cell proliferation and crescent formation characteristic of rapidly progressive glomerulonephritis. Some of the renal manifestations: hematuria, proteinuria, were the same as the other glomerular diseases. Edema. Here's a different one: sign and symptom or manifestations: alveolar, membrane damage, and it can cause a life-threatening pulmonary hemorrhage. To include cough, shortness of breath, and hemoptysis, or throwing up, bringing up blood. Treatment would be in an intensive care unit because they are critically ill. It could include steroids, immunosuppressive drugs such as cyclophosphamide, and other treatments may include dialysis, plasmapheresis, and exchange of blood. With these folks, there's a high risk of death, and it usually is secondary to hemorrhage in the lungs and respiratory failure. Nephrotic syndrome. This is our third immunologic disease in the kidney. The system results when the glomerulus is excessively permeable to plasma protein. It causes massive proteinuria, and this leads to low plasma albumin and tissue edema. So you see some of the causes. Primary glomerular diseases are under here. Extra renal causes: systemic lupus can cause it, diabetes, amyloidosis, infections of all sorts, and we know glomerular disease processes are caused by all sorts of bacterial. Viruses, protozoa, can be caused by neoplasms such as Hodgkin's disease, solid tumors of the lungs, colon, stomach, breast, leukemias, allergens. Some of the drugs down here, and I changed this last one. I had heparin here, which was mentioned in several, it might have been a totally different textbook we were using. In your book, in their list, and I caught this and changed it, I added this heroin here. So we see non-steroidal inflammatory drugs. We know they're nephrotoxic. Captopril or captopril could cause nephrotic syndrome. But nephrotic syndrome is a disease not only of the kidneys. You're going to see these signs and symptoms and problems. Here we go. Characteristic manifestations: massive proteinuria. They also have high cholesterol, low protein in the blood, or hypoalbuminuria, infection, low calcium, increased coagulation. This increases risk of thrombosis or deep vein thrombosis, pulmonary edema. What we're going to do with these folks: ACE inhibitors we're perhaps going to be given, NSAIDs, low sodium diet. If their GFR is normal, dietary protein is needed. If the GFR is decreased, they need decreased dietary protein, because we know protein, the more protein the diet, it does make the kidneys work harder, so we're going to watch that carefully. Thiazide or loop diuretics, sodium restriction, daily weights, strict INO. We're going to measure the girth and edema of lower extremities. Watching, the skin carefully, giving gentle care to the skin and frequent assessment. We want to give them small, frequent meals because they're very exhausted, but they still need to. We got to watch that nitrogen balance, that it doesn't go into a negative. Support for their body image because of the massive edema. The hyperlipidemia, so we're going to give those lipid lowering agents, anticoagulant therapy, we mentioned that, steroids, immunosuppressants such as cyclophosphamide, and we're going to be careful to avoid contact, and we're going to talk to the patient about this with those who have infection. She has a lot of edema, massive in the legs. Renal vascular problem, nephrosclerosis, renal artery stenosis, and renal vein thrombosis. Most of these aren't epiphany, so we're just going to mention them, but things that cause circulatory problems to the kidneys. Nephrosclerosis, like sclerosis in the body, this is a thickening of blood vessels. Well, this is the more specific thickening of the blood vessels in the kidneys, and this causes a decrease of circulation to the kidneys. This occurs with hypertension, atherosclerosis, and diabetes. It generally occurs in adults 30 to 50 is when we start having changes, and older. And it usually happens related to hypertension and age. The degree of nephrosclerosis is directly related to the severity of hypertension. It can be accelerated with malignant hypertension, and they're talking about malignant hypertension. They're talking about a diastolic greater than 130 millimeters of mercury. Nephrosclerosis is just a pretty picture of a kidney. I don't really see a change in color to indicate maybe the kidney's not getting enough circulation, but it's just a picture of a kidney. Renal artery stenosis. This is a partial occlusion of one or both of the renal arteries. This can be due to arteriosclerotic narrowing. 1 to 2% of those cases of these folks who have it, it is related to an increase in blood pressure that comes on suddenly. Whenever blood pressure rise comes on suddenly, we want to think kidney, because many times it's due to the kidney. Test: renal ultrasound, CAT scan, MRI, or a renal arteriogram can be done. The goals are to control blood pressure and restore kidney perfusion. Renal vein thrombosis, like any thrombosis, we want to watch, that there is an impedance or an obstruction by a blood clot. This can occur unilaterally or bilaterally to the kidneys related to trauma or due to compression of a tumor or aneurysm. Pregnancy can cause this. If patients have nephrotic syndrome, and we read about, and I stated their problems with coagulation. Surgical thromboectomy may have to be performed with or instead of anticoagulation therapy. Diabetic neuropathy. This is kidney disease common in later stages of DM. It is the leading cause of end-stage renal disease in North America, that is diabetes. Microproteinuria, indicating renal damage, is seen in the diabetic within 10 to 15 years after onset of diabetes. Here are some stages of diabetic renal disease. They are not anything you have to memorize, but just something for you to think about. In stage 1, this is a newly diagnosed diabetic, and they can reverse kidney problems or changes. Stage 2, 2 to 3 years after diagnosis of diabetes, glomerular changes and tubular capillary basement membrane changes. Loss of surface area and scarring we're already seeing. In stage 3, 7 to 15 years after diagnosis, we start seeing that they are throwing out microprotein in their urine. Once they start throwing out microprotein, there's no turning back. We want to keep that at a minimum for as long as possible. And in stage 3 to 4, they might have normal or decreased GFR. So you can see in stage 3, this is when that's starting, that decreased GFR. In stage 4, GFR, decreased BP. The GFR is decreased, blood pressure is up, retinopathy is present. Stage 5, GFR decreases at an average of about 10 milliliters a minute a year. So that's very, very quick, very damaging. Renal cancer. Now, your book talks about renal cancer too. I had in the spring, I put in these 2017 because that was what was the latest out, estimated new cases. And so I have on here the bladder cancer, 60,000 new cases with 18,000 deaths. Excuse me. Renal cancer, 40,000 new cases with 23,000 deaths. And I know that your book does have different stats, but I'm not going to be testing on the stats. I find the American Cancer Society is one of the best, credible, most up-to-date societies for cancer. If you want to know anything about cancer, you go to their site and read their literature. Kidney cancer. So kidney cancer, we see tumors arising from the kidney itself, from the cortex or pelvis, and they can be benign or malignant. Unfortunately, most of them are malignant. Renal cell carcinoma or adenocarcinoma is the most common type. Cigarette smoking is the most significant risk factor. No characteristic early symptoms. Generalized symptoms are the earliest manifestations. Treatment, radical nephrectomy or removal of the kidney, and biological therapy, which is chemotherapy. Other risk of renal cancer: obesity, hypertension, exposure to asbestos and other toxins, and gasoline. That's kind of interesting. It's also increased in those with cystic diseases who are at the end stage renal disease. Renal cancer is known as the adenocarcinoma. Systematic effects: anemia, erythrocytosis, hypercalcemia, liver dysfunction, hypertension. There are 4 stages with substages, and they use the general T&M stages. And T&M we're going to get into more with cancer in one of our last lectures in this class, but T&M is tumor size, T is tumor size, N are nodes, any nodes that have cancer present, M is malignancy or has the cancer spread. So we'll discuss some of these different staging schematics that are used, but this is one of the more general ones, and it's used in renal cancer. Renal cancer signs and symptoms: family history, signs of pain, obvious blood, kidney mass that can be felt, renal brewery, and that's a sign of turbulent blood flow. Signs and symptoms of hormonal changes such as breast enlargement. Usually treatment: radiation, nephrectomy, chemotherapy, thus have limited results. Renal trauma. The kidney has a lot of vascularity, so kidneys will bleed very easily from trauma. We see more and more renal trauma due to more folks speeding and car accidents and things like this and violent crimes. Anybody that arrives into the ER with abdominal or back trauma, we want to start thinking about kidney trauma, perhaps. We want to watch out for a patient going into shock from bleeding, this kind of thing, because they can bleed pretty quickly. So if there's any, as I said, history of trauma to the area around the kidney, or if there's any gross or microscopic hematuria. Diagnostic studies, urinalysis, IVP. This is looking at the circulation with help of a radio OPEG dye. Ultrasound, CAT scan or MRI, renal enterography, looking at the circulation of the kidney. Treatments range from bed rest, fluids, and analgesia to surgical exploration and repair, or, as I said earlier, nephrectomy. Some of the interventions do vary: increase fluid intake, monitor INO, observe for hematuria, and determine the presence of myeloglobinuria. Nephrectomy is done for trauma, for cancer. If not acute, we discuss the incision and presence of dressing and drains with patient. Reassure them related to pain management, and also talk to them about perhaps having a transfusion, that they might be a recipient of a blood transfusion. Nephrectomy procedures: a patient will lie on the side with the kidney to be removed uppermost so they can get it and reach it. Removal of 11th or 12th rib may be necessary to get the kidney. Kidney and all visible tumor, if it's cancer. Renal artery and vein and fascia after tying off the ureter. The adrenal is left intact. A drain is placed. And if they're having a radical nephrectomy, also lymph nodes will be removed at this time. Post-op care: monitor for hemorrhage and adrenal insufficiency. Watching for early signs of hemorrhage, like a decrease in BP or an increase in pulse rate. Watch urinary output of remaining kidney. This is Q hours for at least 24 hours. Pain management, antibiotics to prevent infection. And it may take days to weeks for that remaining kidney to take over the totality of the workload of 2 kidneys. Okay, this is the end of renal 3, and I will be working on renal 4 as soon as possible, and I'll see you soon. Thank you.